Good morning, everyone. So first of all, I really would like to thank the organizers for having me here. And I think it's really important that this is an interdisciplinary session, an interdisciplinary symposium, and we all can learn a lot from each other. And now I'm trying to tell you a little bit about the standpoints of a radiologist and would like to share my insights into functional imaging with MRI with you. So what's the status right now when we talk about MRI? And you know, MRI is a pretty good tool to depict morphology. As you can see in this example, this is a patient with rectal cancer. The rectal tumor is marked by the arrowhead, and the other arrows mark the layers of the rectal wall. So you very nicely can depict the primary tumor. So morphology in MRI is really superb and has been for the last 20 years. So this is absolutely standard, and when we want to image rectal cancer, morphology is very good in MRI. The next step then is when we use morphology, and we've heard about the size criteria when we do some form of therapy, is to measure sizes pre and post therapy. Like in this patient, as you can see, left-hand side, there is the status before therapy, and right-hand side, the status after therapy. And I think here it's pretty obvious. There is shrinkage in the tumor, the size of the tumor has diminished, so we can pretty well conclude that the therapy was successful to some regard. But is it always like this? Of course it is not. There are limitations when we talk about size and morphology. Even if we have responders to some form of therapy, there might be a very slow decrease in tumor size. So we don't capture the decrease of tumor size. And what's very funny is that even in responders, the tumor may increase in size because under therapy there might be edema or hemorrhage developing, so it might be puzzling really to tell the tumor is getting bigger, but it's still a responder. Then the next point, can we really well differentiate between vital rest tumor and scar tissue? And the answer clearly is not. So morphology is pretty tough in this regard. And last but not least, I really have to apologize. When you give a case to 10 radiologists and have them measure the tumor, you get 10 different results. So there is a very high variability of your measurements. All limitations when we talk about size and morphology. So the next step is to wonder, are there solutions? And the answer is yes, there is a solution which is called functional imaging. We have to get away from pure morphology and move towards the direction of functional imaging. And I would like to discuss in the beginning two aspects and two methods of functional MRI with you. The first, which is pretty well established, is called DWI. This is the acronym for diffusion-weighted imaging. And on this chart, you nicely can see on table A, the water molecules, they have a free motion. And we can measure this free motion. And in chart B and C, you can see how the motion can be restricted in tumor tissue because there is a high cell density in figure B, or there are damaged cells in figure C. So the water motion, the motion of water molecules is limited in cancer tissue. And this restriction of water motion can be imaged by means of MRI. And how does this look like? So again, an example, left-hand side, you have the morphology image, and on the right-hand side, you have the DWI image. It might not look very nice at the beginning if you have a look at it, but you can clearly see the tumor marked by the white arrow. So it's like an on-off situation. DWI helps you to identify really vital tumor tissue. How can we use this as well? Therapy monitoring. And this is a very nice example. So on the left column, you have the morphology images. Right column, you have the diffusion-weighted images. And you have different time points. So beginning, time point 0, and then therapy starts. And we have the time points 2 weeks and 6 weeks after chemotherapy. And now have a look, what happens to morphology? You can see the tumor And maybe the size is shrinking, but I'm not fully sure. I'm not really sure if the size has decreased. But now have a look at DWI. So at the beginning, very bright. So diffusion restriction. And then after time, you can see that the diffusion restriction diminishes. So it gives you a very, very nice marker to see that your therapy succeeded in the end. There is one argument or one issue. Do we really need time to monitor DWI, or could it be also be done that we start right from the beginning, before we initiate the therapy, to have a look at the diffusion-weighted imaging? And I just briefly want to explain you this chart. So you see different responder groups, so good responders, non-responders, and you see that the initial DWI values pre-therapy already differentiate pretty much. So this is something very promising. Even though you're not starting your therapy yet, there might be a predictor using DWI whether your therapy works or not. It's very preliminary data, but I think it's really, really promising. So DWI overall, it's very well established. So all MR machines can do it. And if you do imaging of GI cancer and your radiologist tells you, no, I cannot do DWI, he's lying. So you really have to force him to use DWI. This is standard nowadays in clinical routine, but also for clinical trials. So DWI should be included in every MR protocol when we talk about GI tract cancer. There is a second method, and this is perfusion analysis. And this is a little bit more complex and more sophisticated, so not every site will be able to provide perfusion analysis of cancer tissue. How does this work? So we apply a contrast agent intravenously, and there is a theoretical two-compartment model, the blood plasma and the extravascular or extracellular space. And what we do is we analyze the time-dependent distribution between the two departments. And in fact, tumor tissue, vital tumor tissue, behaves differently compared to non-vital tumor tissue or to normal tissue. And this can be then translated into some factors or to some values like K-trans or KEP. And the next slide actually should just underline that it's not really simple, it's not easy, not everyone really can do it. So here we deal with a large metastasis of a rectal cancer. The metastasis is in the soft tissue of the left iliac side. And you see on the left side the situation pre-therapy. And you see it is color-coded, so you can translate your perfusion values into colors. And right-hand side, you have a status 7 days post-therapy, and you nicely can see that the colors change. So tumor biology changes. Perfusion can assess this. Again, can everyone do this? I don't think so. It's, again, quite complex and quite complicated, whereas DWI, it's really straightforward. And this is also underlined by this study saying that actually perfusion MRI should not be included in every clinical situation and in every trial. Now, ladies and gentlemen, I need your help. Me as a radiologist, you know we deal with black and white images. So if you have a look at this cartoon, this is a cartoon of New York City, which we know is called the Big Apple. And I really would like to ask you, find the apple. There is an apple hidden in this image. And I'm really wondering if you can detect the apple. It's tough, right? It's pretty tough to see the apple. And now I want to show you how our colleagues from nuclear medicine facing this problem. They see images like this. They have a very high contrast, colorful contrast using the PET tracers. They see something, but they don't know what it is. And now, what's the conclusion? We have to put the two imaging modalities together. MRI, very high soft tissue contrast, but no functional or hardly functional imaging or and the PET component. And if we put everything together, so MRI and PET, we get an image like this, and you very briefly, very nicely can depict the apple. So it's very easygoing, straightforward. And this is the basis that we now use PET MRI. They are the first PET MR scanners installed worldwide. The first ones were installed, I think, in 2011. And this is really nice because you can simultaneously acquire MRI images, morphology, DWI on the one hand, and the PET images on the other hand. And we know that, for instance, if we use certain PET tracers like FDG, they are stuck in the cell. And if the metabolism and the proliferation rate of a tissue is high, we have a very high FDG uptake. In conclusion, if your therapy works and there is decline of FDG uptake, and we've heard about this 2 talks before, there's also a decline of vital tumor cells. So this is a very nice tool when we talk about functional imaging. This is a case I would like to share with you from our department. We are very lucky in Essen because we have such a PET MR scanner. And this is a rectal cancer. And you nicely see the PET information on the image on the upper left, and all the morphology information plus DWI and everything put in one examination. It's also important when we talk about tumor recurrence. It's hard, as I said, to differentiate between scar tissue and recurrent tumor, but if you have the PET component, it's very easy to see where is vital tumor. So in summary, I think the assessment, not only on a clinical basis, but also in clinical trials, always should be a combination of morphology and functional imaging. DWI, ladies and gentlemen, is really well established. Again, force your radiologist to use it. Don't get frustrated if he tells you, no, I cannot do it. This is not true. Everyone can DWI. Perfusion is definitely much more complex, and only dedicated centers who have a high knowledge about it would use it. And I think in the future we're going to talk much more about hybrid imaging like PET MRI. So in the end, I would like to ask you these questions from a radiology standpoint. Are we already set up? To some regards, yes, but there are limitations. We have to standardize the procedures. Not every DWI imaging tool works the same in different places. The question is, when is the right time point under therapy to use those tools? And of course, in an ideal world, we would use it even before therapy. And last but not least, and this is effective date July 5th, 2013, right now there is unfortunately still no validation of the predictive power of those methods. We have insights into tumor biology by using PET and DWI and perfusion, but we still don't know really about the clinical value. So we talked about progression-free survival, overall survival. There is still no data out in the literature which proves that those concepts of functional imaging are really helpful, which does not mean that they aren't. I'm pretty much convinced that they are. And so my consumption is that we really need to work together to establish those very nice tools. And how does the future look like? And this also has been mentioned today. I think we need to use multi-parametric imaging or multi-parametric medicine individualized. Not every tumor is the same. In some tumors, DWI might work, in another it might not work. So we need to use different tools, not only DWI, but also morphology, clinical data, tumor markers, and PET imaging, and putting all together. And I think by this, we can get the best benefit for our patients. Two references that I would like to share with you if you are interested in the technology of functional MRI, and with this I would like to thank you for your attention.